We can hear you. We can hear you. Yeah.
Okay.
Shall we start, madam? Yeah. I think it's already 8 o'clock.
Can I start?
Yeah. We can start. Yeah. Inviting Vimala madam for the introductory remarks.
Okay. Good evening, distinguished speakers of today, Professor Prasad Devarajan and Mark Mitchneff, my dear friends, Dr. Susan, Dr. Radhika Kashi sir. I welcome you all to this meeting. Now we understand that this webinar sponsored, ISN sponsored Sister Renal Collaboration Program was started in 2018 and it was started at grade level, probably the assigned level was C. Now after 2 years, it has been upgraded to level B. And now we know that this is possible only because of the dedicated and very hard work done by Dr. Susan, ably assisted by Dr. Radhika, and they deserve to be congratulated for this. Now we all benefit from this webinars, and the first of its kind was in 2018 and 2019, both of which were attended by Professor Prasad Devarajan, whom we interacted in person, and by his physical presence, we learned a lot of things and we were indeed benefited. So he needs no introduction to this audience. Professor Mike Mitchneff is the authority, I understand, on cardiovascular disease and chronic kidney disease. And he is here to speak to us on hypertension in the neonate. And this webinar, I also understand, is going to be attended by more than 200 delegates from all over India. I am sure that you will really benefit by our interactions. One more thing I would like to mention was Dr. Susan has developed her pediatric nephrology of SCT Hospital, emulating the Cincinnati Children's Nephrology Department. And our department has grown so well, and that shows how Cincinnati Children's Development is functioning. I thank Professor Devarajan and Mark for their contribution to development of nephrology of SAT. And with this introductory remarks and wishing you all the best and a fruitful session, I invite Professor Devarajan for his talk and rocks in kidneys. Over to you, sir.
Thank you very much. Thanks to all of you for joining. I'd like to start with having Mark Mitchneff talk about hypertension in the neonate. As Dr. Vimala said, Mark is probably the world's expert in pediatric hypertension, and he's been here at Cincinnati Children's for 20 years as the director of the hypertension program here. So Mark, all up to you.
Well, thank you, Prasad. Let me share the screen with everybody. Give me a minute. All right. Hopefully now, right? Trying to get. Oh. All right. Can everybody see this?
Oh, yes.
Yes.
All right, so I'm going to start. As you can see here, the title is A Practical Approach to Neonatal Hypertension. So the internet is not working very well. We'll try to it's a little bit slow. But anyway, this slide shows you some guidelines from different hypertension societies. For example, this one.
Excuse me,
The slide didn't move.
The slide didn't move. I guess it's not in the slide full screen mode.
That's very strange. Okay.
In the presentation mode. Should be in the presentation mode.
Well, it should not be because it should be regular mode. Hold on a second. Let me close. Okay. How about now?
Yeah, it's come, but that's fine.
Yeah.
Absolutely fine. Yeah.
So again, these are titles from 3 different guidelines from societies of European Society, Canadian Society, and Brazilian Society of for hypertension. And you can see here my question: are there any recommendation on neonatal hypertension? And answer here is none. Okay. Now, this one is the latest American Academy of Pediatric recommendation for hypertension. And there is some statement on neonatal hypertension. For example, consensus opinion recommendations only. And you can see here that, for example, we need to use reference data on neonatal blood pressure, and they give some references for that. Oscillometric device should be used, and also measurement of blood pressure at every healthcare encounter. So if you want to go and look at this recommendation, you can go here. But also you can go to multiple review articles that have been published over the last 5-6 years. And I'll just put here titles. You can see here some, most of them were published in pediatric nephrology. Some of them are from neonatologists, and even this one review is, I found that was published in 2017. This is from Indian Journal of Maternal, Fetal and Neonatal Medicine. And again, neonatal hypertension. So you can go to this if you have access to this article. But I will start with the case. And again, my goal today is just to go through this case and see how we approach management of hypertension in neonates. So this is a 2-month-old former 26-week gestation infant. Over the last 2-3 weeks, the NICU team has noted that the infant's blood pressure have been 80 to 105 systolic, over 50 to 65 diastolic. And most of the blood pressure was in the range of 100 to 60s over the last 3 days, okay? So the initial questions, how I would like to approach this, for example, question number 1, is it normal to have blood pressure increased over time in premature babies? If so, how fast and by how much blood pressure increases? And finally, our blood pressure number in the case are high. And basically all these 3 questions asking this question, what are the norms for neonates, for preemies, for blood pressure, okay? So this is a graph from the study more than 10 years ago from by Ampar Lurbe, when she looked at systolic blood pressure over first year of life. And you can see here, you know, for the first months, the blood pressure goes sharply up. And also, you can also see that it's depend how fast it goes, depending on the weight of the baby, okay? The less weight, the more sharp blood pressure increase within first months. First and 6 months, it slightly goes up, and after 6 months of age, basically the blood pressures are similar in all these groups, and they're not going up significantly. Also, if you want to look at the summary, how blood pressure goes up, this is from a chapter in Textbook of Pediatric Hypertension by Janice Dion, and also give you some ideas how blood pressure trends in neonates. So this is a term baby. You can see nice and smooth increase of blood pressure over a few months period. For premature baby, for initially it goes sharper high, and then it goes very similar increase as term baby. For extreme preemies, again, it goes even more sharper, and then goes similarly to term and preterm. I'm talking about the increase of blood pressure. And finally, for small for gestational age, it's actually behaved like premature baby. You can see here, for a particular time period, for term babies, blood pressure is higher than for premature, for extreme premature, and for small gestational age. Now, if you can put all this together, you can see that we can answer the question number 1. Yes, blood pressure increases with age and size, and the more premature, the faster blood pressure increases. And what about the question number 3? Is blood pressure high? So this is a table that published in Pediatric Nephrology a few years ago, and now actually you can go to textbooks and also see these papers. And by the way, the paper, the same table published in Indian Review for neonatal hypertension. But this table shows you the blood pressure changes in babies of regarding post-menstrual age. Okay, so in our case, it's a 2 months old baby, 26 weeker. Now he is 2 months old, right? 34 weeks old. And if you look here, the 95th percentile for this baby is 85/55. Okay. Now, this is from, I found the paper looking at normative blood pressure data for Indian neonates, okay? And this is a table looking at day 4, 7, and 14. And if you look at 95th percentiles, for example, for 34 weeker, the same as for, in my case, the 95th percentile are lower than in the table that I showed you before. Now, so you have to really think about what normative values you want to use for a local, conditions. Now, from now on, I'm going to use the table by Janice Dione. So, the blood pressure in this case, 100/60, and the answer is yes, they're high. The next question, of course, how was it measured? Okay, because this is very important. This paper was just published a few months ago in Journal of Pediatrics. The title is Method of Blood Pressure Measurement in Neonates and Infants. It's a systemic review and analysis, and this is on behalf of the International Neonatal Consortium. And you can see the position of the baby at the cuff, and basically what you have to remember that use of blood pressure cuff with cuff width of arm circumference ratio close to 0.5. Placation, typically it should be done on the right upper arm. What about leg blood pressure? This consortium recommends only for a few days to use it in the legs, because after that it becomes not reliable. However, if it's impossible to measure blood pressure in the arm, I would say that the blood pressure in the leg is still appropriate, but you have to look not at absolute value of blood pressure, but on the trend of blood pressure over days. And you can see if it increases the same or not. Methods, as I said before, it should be a oscillometric device. Now, this neonatal consortium actually doesn't recommend to look at systolic and diastolic blood pressure. They recommend to use at mean arterial pressure, with some caveat. The caveat is that if mean arterial pressure less than 30, that number becomes unreliable. So that's multiple caveats and the consideration how to measure blood pressure, but this is a very important table as far as my concern. All right, now, so assume that we have accurate blood pressure measurement. The next question is, of course, why is it elevated? And this is just one of the tables, and you can go to many reviews and you will see very similar table looking at causes of neonatal hypertension. And I will just summarize it by a few categories. For example, most common category is renal and renovascular. There is a pulmonary causes, cardiac causes, endocrine causes, some medication intoxications, neoplasma, neurology, and some other, which is a miscellaneous causes. So basically, we have more than 50 different causes of neonatal hypertension. So in our case, of course, you have to start with history and physical, okay? This baby had a steroid use, umbilical artery catheter. He has BPD, bronchopulmonary dysplasia. He remains on supplemental oxygen. He tolerates feeds and growing appropriately, and physical exam, basically nothing specific. You have to check some volume status, dysmorphic features, murmur, abdominal masses, brood, genitalia. So typical physical exam looking for specific causes of high blood pressure. So, and this is just a summary that I think very important, and I highlighted it here, that most patients do not exhibit the usual symptoms of hypertension that older children do, and symptoms and signs are often difficult to differentiate from those of concurrent medical conditions such as cardiorespiratory failure, feeding difficulties, irritability, and gastrointestinal symptoms. So what about labs and imaging studies? Again, this is one of the tables, and we can look at initial testing. Nothing's super exciting here, but yes, we all know that we want to do kidney ultrasound. We want to do like a cardiography to rule out kidney disease and heart disease, and we do some basic screening, blood work, and urine tests. And of course, for this, our case, assume that in all labs are normal. Okay, so what is the cause of elevated blood pressure in our case? We can put the assessment based on history, physical exam, labs, and imaging studies. Likely cause of elevated blood pressure could be, maybe it's going to be bronchopulmonary dysplasia, maybe it's going to be steroid use, or maybe microthrombosis, right? All of this. So if you look at most common causes of systemic hypertension, this is one of the large studies looking at preemies and term babies. And you can appreciate this, that two most common causes are respiratory and iatrogenic. So use of medication. So pay attention to that, okay? As far as BPD, I try to find the why patient with bronchopulmonary dysplasia have elevated blood pressure. And there is no good answer. It could be anything: increased level of catecholamines, angiotensin, antidiuretic hormone, altered neurohumoral regulation. So basically, you know, this summary shows you that we really don't understand the cause of high blood pressure in this condition. There is another paper looking at systemic arterial stiffness in these kids. They show that it's a little bit increased. Maybe that's a cause, but I am not yet, sure about this. So what about next step of questions? Should treatment with antihypertensive medication be initiated? Okay. Again, if so, what type of medication to use? Now, there is a few general considerations. First, treat the cause if known. And of course, if you need to discontinue or reduce dose of offending agent if hypertension drug related. You also have to look at fluid management. Maybe we give too much fluid and they're fluid overload. And of course, you have to look for some conditions that can be fixed. For example, UPG obstruction, tumor, etc. So surgery may be indicated. And another general consideration is, what are the indications for medications, okay? So of course, if you have a child who is critically ill or symptomatic, immediately upon confirmation, for example, child has congestion, heart failure, and seizure, and you think that it's related to significantly elevated blood pressure, don't even wait, start immediately. Of course, if you found that this kid have LV hypertrophy or, for example, mildly decreased kidney function, which is target organ damage, you have to start blood pressure medication. And that's what Dr. Flynn said. After that, who knows? And the reason why he put this statement is because of that. Basically, it's an expert-related condition, but most experts agree that severe hypertension greater than 99th percentile for post-conceptual age and sex and size should be managed with pharmaceutical agent, okay? So remember, above 99th percentile. The third general consideration is what type of medication to use. This is one of the large papers that I already brought one of the table from this paper, but you can see here 4,000 neonates were evaluated. Hypertension was found in 1.3%, only 53 kids. And this is how these children were managed, okay? You can see multiple classes of blood pressure medication, oral medication or IV medication, and half of these kids were on multiple blood pressure medications. So calcium channel blocker and vasodilators were the most commonly used medication, at least for this study. This is another study from Kansas City. Similarly, you can see many different classes of blood pressure medication being used: vasodilator, ACE inhibitors, alpha and beta blockers, and calcium channel blockers. 45% were exposed to more than one antihypertensive medication. So it's consistent that, you know, frequently we start with one, and then unfortunately we have to add another medication to get a better response. So in our case, I think, these are the classes of medication that are available on market: diuretic, calcium channel blocker, vasodilators, alpha beta blockers, ACE inhibitors of clonidine. If we think that the possible cause is bronchopulmonary dysplasia, it is likely that many of us will start patient either on diuretics or maybe then add calcium channel blocker. What about spironolactone? I will get a little bit off my case, but I think it's very important to discuss it because there's some new data about possible causes of high blood pressure in neonates. And I'm actually talking about plastic, which, phthalate is one of the chemicals that found in plastic. And you can see here on this figure on the right that many neonates are exposed to different types of plastics, okay? The key point here is that the exposure to plastics can be pro-inflammatory. It also been associated with some neurodevelopment and hepatotoxicity. As far as hypertension, this is studied in older kids, looking at urinary phthalates and associated high blood pressure. That's been already published. What about neonates? This is a series of studies from Portland, Oregon by Randall Jenkins. And first, he did some kind of interesting study looking just at characteristic of hypertension in preemies. And what he found that this preemie with hypertension and without chronic lung disease had low renin activity level, okay? The hypertension was transient, and interestingly enough, they responded to spironolactone. And when he put this all together, he found this study, and this study showed that phthalate metabolites actually cause a sodium retention, similarly to licoric-like action by inhibiting enzyme 11-beta hydroxysteroid dehydrogenase type 2, okay? And based on these papers and observations, so he published in other papers. He did this study looking at phthalate-associated hypertension in preemie. Okay, the hypothesis here was following: the neonates are exposed to phthalates in NICU, which will lead to hyperaldosteronism with increased serum aldosterone level and decreased plasma renin activity. Of course, that leads to hypertension. You give spironolactone, and that might lead to normal blood pressure. Okay, that's the hypothesis for this study. And actually, he proved it by looking at urinary metabolites, and they were associated with prior IV and respiratory tubing metabolite exposure. Both IV and respiratory metabolite, phthalate metabolite exposure were greater in hypertensive infants. Systolic blood pressure was related to exposure from IV fluid, but not from respiratory, so not from tubing. He also found that urinary cortisol-cortisone ratio was related to IV phthalates, metabolites, and systolic blood pressure. So this is kind of very interesting study. I'm not advocating to using yet spironolactone in these kids, but I think more study needs to be done to prove this concept, okay? Go back to next general consideration for treatment. What about duration of therapy? This study again from Kansas, and you can see here that median age at first exposure was only 15 days, but median duration was very short, was very transient, okay? So from the experience from this study and other experiences, we can say that most infants require treatment for only short period and rarely more than 6 months. Okay, now back to our case, we follow, what's gonna be the follow-up after discharge? So infant discharged from NICU at 36-week post-menstrual age and seen in the hypertension clinic 1 week later. He's taken hydrochlorothiazide and amlodipine, and his blood pressure in hypertension clinic 96/62. Is blood pressure still high? Well, you go back to this table, and again, you can see that now he is 30-week-old, and you look at the 95th percentile is 92/65, and 99th percentile is 97/70. Remember, 99th percentile, it's kind of cutoff point for starting or continuing blood pressure medications right now. That's consensus. So what should be our approach now? Should we continue the same medications, increase the dose, or do nothing? Should we start weaning? If so, how to wean? When to stop blood pressure medication if we decide to wean? And what is the follow-up after stopping blood pressure medication? So that's all important questions, okay? And again, I think I like this statement because it show us that there is no single way to do that. The optimal management for hypertension in infants remain uncertain due to lack of evidence regarding long-term outcome and clinical trials evaluating safety and efficacy of antihypertensive agents in this age group. As a result, a therapeutic recommendation generally rely on expert opinion based on clinical experience and judgment. So anyway, so infants now 6 months old. So basically, after discharge of from NICU and seeing this kid 1 week later, we decide not to change anything. He's still going to be on 2 blood pressure medication, and now blood pressure is 98/59, but he is 6 months old. Okay, and again, we have similar question to ask: should we continue the same, start weaning, how to wean, when to stop, and what we need to do after stopping blood pressure medication? Now he is 6 months old, and now we have to look at different normative values. We can't use the previous tables anymore. And again, you look at this, what recommended right now, right? Normative blood pressure value, first year of life. This recommendation more than 30-year-old. And you can look at this graph, for example, and look at 95th percentile for girls and boys up to 12 months. And basically after 2-3 months life, the blood pressures are stable, but they're quite high, at least in these tables, right? And this is a concern. And the concern is because if you look at normative blood pressure values, for example, this table is from 2017 American Academy guidelines, right? And you look at 1-year-old kid or 2-year-old and 3-year-old, and 95th percentile, 102, 104, 106. These numbers are less than in the previous figures that I showed, okay? So we have to be careful. So why we have this discrepancy? One of the reasons is because these numbers are from manual blood pressures from this table, and the previous graphs are oscillometric measurements. But again, we need to be very careful how we evaluate and what normative values we use. And my guess, more study needs to be done to look at this. So the final question that I ask is, what is the outcome of hypertension of NICU graduates? And we don't have much data, but this is one of the a study that was done by one of my fellows. And we utilized data from Midwest Pediatric Nephrology Consortium. This is 124 neonates from 13 children's hospitals, and you can see all of them were preemies. All of them were on antihypertensive medication after discharge from NICU. And then the results showed that most of them actually got better, okay? So 92 kids, or 76%, came off antihypertensive medications, and only 7% of children remain on blood pressure medication at 2 years of age. Again, in our study group, 50% were using calcium channel blocker. The bottom line here, they all almost got better, okay? So I will conclude with this slide just to summarize that neonatal hypertension is quite rare. All recommendations on management of neonatal hypertension are based on expert opinion and expertise. Most neonates will be off antihypertensive medication by 1 year of age, but we still need to have a long-term follow-up since there are significant risks to develop hypertension later in life. And as you know, the prematurity associated with high blood pressure in adolescent years, but this is completely different lecture on prenatal programming and development of hypertension. So I'm not going to discuss it here. Thank you very much. And I'm going to answer the questions, and let me just stop it here and finish, and I will stop sharing.
Thank you very much, Mark. That was very informative. The one message I heard very clearly is plastic can cause hypertension, so throw away all your plastic containers.
There you go.
Will your recommendation for treatment change if the infant had chronic kidney disease, stage 3, stage 4 CKD?
Well, I think the recommendations are very similar to what we try to do in older kids, right? But again, as you know, these kids, if their blood pressure is not very well controlled, you know, that's will lead to acceleration of progression of chronic kidney disease. So for older kids, the recommended level to have it below 90th percentile. Okay, so again, you can use these tables and go back and again, you know, look at the 90th percentile and try to control it. Now, so that's a level of blood pressure, but the next question is what medication to use. And I would say it's also the same. To delay the progression of chronic kidney disease, at least in older kids, we know that it's ACE inhibition, right? For younger kids, I don't think that there's any contraindication to use ACE inhibitor, especially if they're older than 36 weeks of age, right? As you know, that we don't want to use ACE inhibition for very premature kids and those who have not developed yet their kidney system. So that would be my recommendations.
Thank you. Any other questions from the audience for Mark?
Yeah, any precaution that you will have to take if we are, means after 36 weeks, if we happen to use AC inhibitors or ARBs in the small neonates, is there a risk of hyperkalemia? Is there a risk of worsening of renal function as the tubulointerstitial development is still going on till 2 years of age? So are we going to harm these kids by giving ACs and AC inhibitors and ARBs?
So I think with your question, you already got the answer, right, Susan? Because basically, yes, of course, that's what you do, right? You have to be very careful. If you start ACE inhibitors in this neonates, and actually probably in older kids as well, but for neonates, we need to be even more vigilant and careful. Yes, of course, you repeat, you know, kidney test and look at their potassium level and look at their serum creatinine level. You also talk to parents and see, you know, if within first 2 days their urine output is decreased, they pee less. So all these are very valuable consideration. And of course, you know, we don't want to use ibuprofen at the same time, right? So non-steroidal, we definitely have to be very careful, especially if, you know, there is some kidney dysfunction in these kids.
Thank you, Mark.
Sure.
Any more questions?
Dr. Mark,
Yes.
I would just like to know, how do you measure blood pressure in neonates at Cchmc?
Well, the last word in neonates, okay.
How do you measure hypertension in neonates at your center?
Oh, in our center. Well, it's a great question. In NICU, of course, we use a oscillometric device, right? So while they're in NICU in the hospital, yes. But when they come and see me, we definitely would like to use manual blood pressure, okay? That's what we use. And our nurses are very well trained. And sometimes actually you need 2 people to be sure that blood pressure is measured appropriately. And it took a lot of training to get blood pressure measured. I'm not advocating for that for everybody because, you know, first of all, you need to have appropriate blood pressure cuff. And the most important, the nurses need to be trained. In majority of cases, you know, you have to do a oscillometric device. That's perfectly fine. But when you do by oscillometric device, don't stop just using one measurement, okay? Studying in older kids showed that if you use a oscillometric device, you need to measure at least 2-3 times in the same position on the same arm, okay? So, and the first measurement frequently when you use a oscillometric device is overestimate the real blood pressure. So, and that brings actually, it's a very good point, because when you look at this graph that I show you with very high 95th percentile for this premise, the problem is that blood pressure in these studies and multiple studies were measured only once, okay? So you need to do second and third measurement, which are much more, much better correlate with manual blood pressure than the first oscillometric measurement.
Thank you. And one more question I had. Does the blood pressure vary in such small neonates and like the early infants, in early infancy with their activity? Like, do you advocate that the blood pressure should be measured when they're sleeping?
Well, you know, the best, you know, if you go to older recommendation for blood pressure measurement, and you can find this table, I removed actually this table because there is no such recommendation for, you know, in the new article, right? But the old recommendation were ideally you have to measure it when child is 1.5 hours after feeding and sleeping or quiet, okay, which is basically unrealistic in many cases, as you understand, right? So that's my guess. That's the reason why the new recommendation removed this consideration from measuring blood pressure in neonates, because most of the cases, you know, I frequently see situation when the kid is screaming and he's hungry, right? Even 1.5, 2 hours. So what can you do? You start feeding the kid. And when you start feeding the kid, you know, he's more quiet, but at the same time, it's exercise for the baby, right? So you really have to balance what's the best for him, right? Either to scream or to exercise, right? Ideally, of course, would be better if he's sleeping and do nothing, okay? Be my guest and good luck with that.
Thank you.
Mark, I also scream every time I exercise.
Don't check your blood pressure, Prasad.
Yeah.
Very good. Any further questions for Mark? If not, we can move on.